Hello, thank you for your interest in my poster presentation on the epidemiology of invasive Haemophilus influenza disease treated at a regional hospital in northwestern Ontario, Canada from 2021 to 2022, a case series. My name is Hannah ShortreedH, and I completed this project under the supervision of Dr. Marina Ulanova. I would like to acknowledge that both authors have affiliations with the Northern Ontario School of Medicine University, myself as a student and Dr. Ulanova as a faculty member, and that this presentation has received support from NHRC in the form of Dr. Ulanova's contributions as part of her employment with the university. To begin, Haemophilus influenza is a facultatively anaerobic gram-negative coccobacillus colonizing the upper respiratory tract in a large proportion of the pediatric and adult population. Colonization is often asymptomatic, however it can cause severe infections, including septicemia, meningitis, and more. Differentiation of strains is based on the presence or absence of a polysaccharide capsule, with encapsulated strains designated as serotypes A through F and non-encapsulated strains termed non-typable H influenza, or NTHI. Historically, serotype B was the most virulent strain and caused significant morbidity and mortality in pediatric populations before the introduction of an HIV conjugate vaccine in the 1980s and 90s. This opened an ecological niche for non-B serotypes, with most infections now caused by non-typable strains and occurring in those less than 1 year of age or in older adults with comorbidities. The objective of this study is to contribute to the continued surveillance of Haemophilus influenza disease in northwestern Ontario by describing the epidemiology of H. influenza in the population. In terms of our methods, the microbiology laboratory at the Thunder Bay Regional compiled a list of invasive H. influenza isolates from May 1st to 2021 to December 31st, 2022. All isolates were collected from blood and characterized by the Public Health Ontario laboratory using standard methods. Patient charts corresponding to these isolates underwent retrospective chart review for main epidemiological data. Our key results are summarized in Table 1. 1 pediatric and 6 adult cases with the following blood isolates were reported: 2 serotype A, 2 non-typable strains, 2 serotype F, and 1 serotype E. One of the non-typable isolates was resistant to ampicillin and was beta-lactamase positive. Remaining isolates were sensitive to all antibiotics tested. 3 of the patients reported in this case series identified as indigenous, and the remaining were of non-indigenous status. Pneumonia and bacteremia were the most common clinical presentations. 2 unique adult cases, bacteremia caused by serotype A and epiglottitis secondary to serotype F, were additionally reported. The length of hospital stay ranged from 1 to 29 days with a mean of 10 days. 2 patients were admitted to the intensive care unit, and the case fatality rate was 14.3%, with 1 patient expiring after a lengthy ICU stay. This patient had significant comorbidities, including type 2 diabetes mellitus, polysubstance use, and coronary artery disease. Regarding our key points of discussion, H. influenza continues to be a causative agent of serious invasive disease in northwestern Ontario. We calculate the incidence rate of disease to be 1.81 per 100,000 compared to the provincial rate of 0.54 per 100,000 in 2021. This provides insight into the increased burden of disease in northwestern Ontario. Regarding the distribution of serotypes, no cases of serotype B were reported, demonstrating the impact of universal pediatric immunization against serotype B. The clinical presentations shown in Table 1 were similar to those reported in previous surveys of the region. However, 2 cases, Case 2 and Case 5, are less common. Case 2 describes a 24-year-old male with a history of polysubstance use and recent non-penetrating trauma to his head and back. What is unique about this case is that invasive serotype E is one of the least virulent and uncommon serotypes typically affecting the young or the elderly with comorbidities, making the appearance of it somewhat rare in an otherwise healthy 24-year-old. Substance use and physical trauma have both been linked to an impaired immune response and increased susceptibility to bacterial infections and could have predisposed this patient to developing serotype E bacteremia. Case 5 described a 64-year-old female patient with serotype F-induced epiglottitis, a relatively rare manifestation of serotype F infections in the post-serotype B vaccine era. Before the implementation of this vaccine, serotype B was the main cause of epiglottitis and supraglottitis in children and adults. Several cases secondary to H. influenza infection in adults have been described in northwestern Ontario in recent years, including 3 cases of epiglottitis reported from 2011 to 2018, 2 of which were caused by serotype A, and 1 of serotype F-induced supraglottitis in a 57-year-old female. In conclusion, this case series demonstrates the high burden of invasive disease caused by non-B H. influenza affecting northwestern Ontario. Continuing surveillance of H. influenza disease will help to identify risk factors for serious infections more accurately, with the goal of developing prevention strategies. The authors wish to thank Wendy Gulaker and Georgia Carr for their help in identifying cases of invasive H. influenza disease at the Thunder Bay Regional. This case series was written in association with our ongoing study entitled Continuing Surveillance of Invasive Haemophilus Influenza Disease in Northwestern Ontario. Thank you.